So today's Learn and Share conference call is on attention, executive function, and epilepsy. And we're very happy to have with us Dr. Christine Trask, who's a pediatric neuropsychologist at Rhode Island Hospital. Dr. Trask, can you please introduce yourself briefly and just share a bit about your clinical and research interests and also your experience with epilepsy?
Sure. So I went to college in Maine at Bates College, and I did my graduate training at St. Louis University, and then went on to do my specialized training in neuropsychology at both the University of Rochester and the University of Michigan Medical Center before coming here to Rhode Island Hospital and Hasbro Children's Hospital. As Russ was mentioning, I'm a pediatric neuropsychologist, so I have broad training as a clinical psychologist with sort of specialization in understanding how people think and learn and how the brain develops over time and how that affects how people behave and act. I have particular interest in epilepsy in children, both in terms of the impact it has on them with their learning, as well as how families adjust and adapt to that change. And then I also collaborate in research in that area in addition to clinical work with one of the neurologists here, David Mandelbaum, who's been particularly interested in the cognitive side effects of anti-epileptic medications on cognition.
Great. So when we think about epilepsy, probably the most common cognitive difficulty that's brought up by people with epilepsy is memory. And with epilepsy, memory problems are often related to changes in the hippocampus and the temporal lobe. But the frontal lobe is also affected by or involved in many cases of epilepsy, and this can cause a different set of problems. So can you talk a little bit about the frontal lobe and the cognitive functions it oversees, particularly attention and executive function, which are the focus of this discussion?
So the frontal lobe of the brain is one of the last structures of the brain to develop, and it doesn't fully develop until young adulthood. It is sort of like an executive in many ways. It helps control and direct the brain, which is why when children are young and the frontal lobe isn't well developed, you need an adult to regulate them, to tell them what they need to do next, to help them plan their day, to help them know when something could be dangerous and not a good idea to do. And as your frontal lobe develops, that takes over that ability and starts managing that for you. So the frontal lobe will direct your attention. What should you focus on? What should you screen out? It helps you prioritize and think about what's most important or least important. It helps you with time management, planning your day. It also has to do with some regulation related to emotions. It can damage in different parts of the frontal lobe can either lead to sort of a dysregulated emotional state where people's mood can change quite dramatically and quite widely. So people might be very happy at one moment and then very irritated the next. It can also damage on the other side of the frontal lobe, can be associated with some depressive-like features where affect is more muted and people may not express their emotion with the same intensity as other folks would. When people think about memory problems, we think about that sensation of not being able to recall something. Where did you leave your keys? What was that person's name again? And we all talk about that as a memory problem. We can't remember that piece of information. But working backwards, that memory step is sort of the last step of a sequence, and we need to think backwards to figure out, was it really a failure of memory or was it a failure of a step leading up to memory? So in many ways, attention is one of the earlier steps. That is, all these things are happening around us. What do we focus our attention on and sort of open the gate and let into our awareness or into our information processing stream? So when you're at a party and there are all these people talking and someone says their name, do you focus on that and hear that name come out of all the background noise that's going on around you? Sometimes attention gets in the way and people don't accurately let that information in to be processed, and it's lost at that very early stage. The next stage is really the organization of information, which is where usually our executive system comes into play. And I often give it the analogy, it's the files in your filing cabinet. Your executive system decides where that information should go, what things are associated with it, what things it's related to or relevant to. And if you have a strong executive system, your filing system makes a lot of sense. You know exactly where to go to get that file or that piece of information you need, so you can readily open your file drawer and find that one piece of information you need. For folks that are having problems with executive functioning, the memory system may be working. Information may still be in their filing cabinet, in their memory system, but they can't figure out where it is. It's just one of a bunch of random pieces of information that are misfiled or jumbled up, and it becomes hard to figure out how to extract the information. And then the third step, that memory step, is a different situation, which is where the information did come through and it was somewhat organized, but then it gets lost out of the memory structure. And that's a third situation that could still lead to that same effect of feeling like you can't remember a specific piece of information.
So I would, assuming it would be an oversimplification to say that attention and executive functions are controlled exclusively by the frontal lobe. So can you talk briefly about how other parts of the brain may be involved?
So when we first started really studying the brain, there was a real attempt made to find what part of the brain did what, and we wanted everything sort of neatly housed in one location. So we would talk about memory being in the temporal lobe and attention abilities being in the frontal lobe. But as we've become more sophisticated in the way we look at the brain, we understand that it's really very interconnected. Even though we have these hubs where significant activity or work occurs, it's really relying on the connection between different areas. So the frontal lobe has a very strong connection to the temporal lobe. And in particular, it has very strong connections with the basal ganglia as well as the limbic system. And it's those relationships that will help regulate our mood and emotion, that will help regulate our memory, help regulate sort of the smoothness or hand-eye coordinated movements in different ways. The frontal lobe also connects all the way to the very, very rear of the brain, and that also helps create circuits with feedback in terms of some basic sensory processing. What we see of people's faces, what information we encode or organize from what we see in people when we first meet them. So just like as I was talking about, you can have disruptions in the process, cognitive processes leading up to memory. If you have disruptions in other parts of these tracks that connect throughout the brain, you can end up with the same end result in terms of looking like it's hard to remember a piece of information. So, for example, if you're having auditory processing information and it's hard to filter out certain sounds and attend to certain sounds, that function is somewhat further back in the brain. But if that area is disturbed, again, information may not accurately come into the brain to be processed well, and then it won't even reach the point where the frontal lobe can work on organizing it if it doesn't come through the system to begin with.
Okay. So with epilepsy, a seizure focus can play a role in the type of cognitive difficulties you have, but the seizure focus itself is not, the cognitive problems you may have aren't limited to where the seizure focus is because of some of these networks and the connectivity.
Correct, and it also gets more complicated, particularly if seizures develop in childhood when the brain is still developing. For example, our brain has a natural desire to preserve language functioning. So if a young child has a seizure focused in the left hemisphere, which typically is used for regulating and managing language, the brain sometimes will work to find another location for language processing to develop, and it may sort of borrow space or borrow energy from other parts of the brain. And so as a result, language may not look as impaired, but we have this phenomenon that we call crowding, meaning if a smaller part of brain now has to do more jobs, something else will suffer, so that even though language may get reorganized to another part of the brain, we may see that there's struggles now in visual spatial processing. Even though that part of the brain looks intact, it's now doing too much work, and it doesn't have quite as much resource to spread across all those jobs.
So you alluded to this already, but how often would are perceived problems with memory actually related instead to impaired attention or the other processes related to attention?
I think it's difficult to say from a clear standpoint because there's a lot of variables that come into play, but I would say from my clinical experience, more often we see problems earlier on in the process. We see disruptions in attention, we see disruptions in executive system, and that it doesn't seem to be exclusively a memory failure when people are experiencing those issues with memory. And so it's very important to really look at those different functions as well to better figure out what sorts of strategies will become helpful for dealing with the issues.
Okay. So how common are problems with attention and executive function among people with epilepsy? Obviously, a lot of people complain and are bothered by memory problems or what they perceive as memory problems. But are there particular types of epilepsy that are associated with higher rates of attention and executive function problems? And do the primary symptoms experienced vary according to epilepsy type?
So I'm going to speak a little bit from the pediatric perspective because that's the area that I'm going to know best. And what's really been looked at most extensively is looking at the relationship of ADHD or ADD, a disorder of attention, and the rates with epilepsy. And we do know that there seems to be a high overlap between those things, meaning that children who have epilepsy are more likely to also show features or signs of attention problems or ADD or ADHD, but also the reverse, that children that have ADD or ADHD are more likely to have abnormalities on EEGs even if they don't have clear seizures or have been diagnosed with epilepsy. So there is this blurring of those lines between them, and the rates, depending on how they're defined, will change how common those types of issues are. So if you talk about it with a stronger definition, that you have to have epilepsy and meet criteria for ADD or ADHD, you might be talking at a twofold increase, so twice as likely to have some of those issues. If you talk about features, so signs of problems with memory or attention or signs of abnormalities on EEG without a clear seizure, then the incident rate goes up quite a bit, and it can be closer to a fivefold increase in the rate of difficulties that are associated.
Okay. And are there, do the symptoms vary according to epilepsy type? Because epilepsy is not a single condition, but are there like generalized epilepsies or partial epilepsy or different epilepsy syndromes? Do you see different types of symptoms in terms of attention and executive function?
So by and large, when you look at children that are diagnosed with attentional disorders, most of the children that are diagnosed with attentional disorders, the focus is on the hyperactivity, impulsivity component. When we look at the part that we believe that is more related to epilepsy, we believe that's more of the cognitive piece of it, the inattention and executive dysfunction that can occur with it as well. Children with generalized forms of epilepsy seem to be particularly at risk for that cognitive component of it. Again, it becomes complicated to understand how much of it is related to the seizures themselves, some of the actual sort of electrical abnormalities that are occurring at that moment, versus also you can see different patterns of behavior that would relate to an underlying shared problem. So, for example, if someone has a tumor or an injury in the frontal lobe, because that area of the brain also controls behavior and restlessness and impulsivity, you may end up with someone with that ADHD-like feature where they have hyperactivity and restlessness, and it's related to that common shared underlying condition, that tumor or injury may result in both seizures as well as that hyperactivity, impulsivity presentation that you might see.
Okay. Are most attention problems classified as ADHD or ADD, or are there attention problems that would not fall under that umbrella, and if so, what would they be referred to?
So part of the complication in our field is the use of different diagnostic systems. Most of the people in medicine either use the DSM-5, which comes out of psychiatry for creating diagnostic systems, or they use what's called the ICD-10, which has other medical diagnoses in it as well. Each diagnostic system has slightly different definitions and categories within them. If I stick with just the DSM-5 or its predecessor, the DSM-4, attentional problems have been sort of grouped together, and one of the things that's been confusing for a lot of people has been the term that's used. So in the DSM-4, we would talk about attention deficit hyperactivity disorder, and even though the term for the group had the word hyperactivity, you had a subset of within that might include people that did not have hyperactivity, and that made it very confusing for a lot of folks to understand, well, do all attentional problems have hyperactivity or not? And clinically, we would use that term ADD, dropping off the hyperactivity from the label, to try to indicate that this was a form without hyperactivity. But the actual diagnosis, the formal term in the diagnostic system, includes the word hyperactivity. So the DSM does not make diagnoses based on the presumed cause for the problem. So for most people that are showing problems with attention, most clinicians will use this phrase of either some form of attention disorder, ADD or ADHD. But there is a class of diagnoses that are in the DSM that draw a connection to a memory or a medical complaint that is affecting cognition. So there is a link to what's causing it, and it's specifically focused on memory. And so there's another category that used to be called cognitive disorders not otherwise specified that in the DSM-5 has been relabeled as sort of neurocognitive disorders. And epilepsy, the difficulties associated with epilepsy could be put into those categories as well, where we would say that we believe that epilepsy is the reason for these problems. It may be affecting attention and executive functioning, but it's also manifesting in disruptions in memory, and that it's something acquired. It's something that has come on as epilepsy has developed, rather being sort of born with those struggles or those issues to begin with. So you might use that diagnostic phrasing as well.
Okay. So you mentioned different subtypes of ADHD. I've heard of there being anywhere from 2 to 3 to up to 7 or more. So what are the main different subtypes of ADHD? And then after discussing that, if you can talk about whether ADHD in people with epilepsy has any unique features. Does it express itself differently in people with epilepsy than in the general population?
So in the DSM-4, you had, again, this umbrella term called attention deficit hyperactivity disorder. Underneath that umbrella term, you had 3 subcategories. You had the primarily inattentive form, the primarily hyperactive impulsive or combined form, which had both inattention as well as the hyperactivity component, and then a form that they called not otherwise specified, meaning that you felt that there were disruptions in attention, but it didn't really meet the criteria for the other 2 categories. In the DSM-5, they've modified it slightly, but again, they still have these main groupings. If it's combined, both inattention and the hyperactivity impulsivity component, or if it's predominantly inattentive, or if it's predominantly just the hyperactive impulsive component. again, by and large, when we have looked at the relationship with epilepsy, the focus has really been mostly on this inattentive group for the most part. That seems to be what seizures as a large group are most related to. Again, if you have focal seizures in the frontal lobe, you can have sort of this more hyperactive, impulsive component as well. But by and large, most of the research with epilepsy is looking more at the inattentive form. And we have seen over time that when we study children and adults also with these diagnoses, that even though they're grouped together under this umbrella term, children that have a hyperactive or impulsive component do look and act very differently than children that just have the inattentive component. So some folks within the field have talked about really trying to separate the inattentive form out of this larger group because it does act and respond somewhat differently.
Okay. With epilepsy, I would guess that in the general population that ADHD tends to have more stable features. Is there more fluctuation or transient symptoms in epilepsy because of its possible connection to seizures and these interictal discharges that happen between seizures?
So again, this is a very complex question. When we look at the evolution of ADD in a population of people without epilepsy, it's not a completely stable presentation. It is true that children have some degree of hyperactivity or inattention that we see in multiple settings, but we do see some variability. So overdevelopment, for example, when children are younger, there's usually a greater incidence of problems with hyperactivity and impulsivity. And as children age and they reach their adolescent years, it tends to switch over, and we see greater difficulties with organization and executive functions. We also can see within the group of children that have ADHD without epilepsy that sleep has a big impact on their functioning and other environmental stressors, so that their behavior and those symptoms are going to wax and wane to some degree given those background issues. So when they're sleeping better, their symptoms maybe are more minimal. When sleep gets more disrupted, it becomes a bigger problem. With epilepsy, we have a number of things that we're looking at being related to why we see attention fluctuating or varying. Again, for people with a generalized epilepsy, particularly, what used to be called petit mal seizures, those moments of staring and not being able to respond has a sort of a classic disruption in attention where you're going to miss information at that period of time. And so certainly the more frequently that happens, the greater difficulty we see with attention processing at that point in time. So to the extent that seizure frequency is minimized, you might see smaller problems. And if seizures are occurring more frequently, you may see greater problems. The same sort of issue if there's interictal discharges of some type or irregularities there may be some transient disruption in what information can come in to the brain to get processed at that point in time. And again, as that is more stable or better controlled, you may see attention looking better or worse. But then layered on top of that, you also have medications, and where medications are in the body system. We know that when we do research, we have to think about how active is that medication in a person's system. Is it just building up? Is it sort of beginning to fade off for a person? Have they been on the medication for a period of time, so those initial transient side effects have diminished out? So there's a variety of things that have to be looked at, and just like with the children with ADHD without epilepsy, to the extent that you have other stressors, if you have disruptions in sleep, if you have disruptions in mood or other emotional stressors, those will also change the presentation of the degree or severity of those cognitive issues. So sometimes we do recommend it's helpful for individuals and families to try to keep logs of the important things such as how frequently seizures are occurring, the medications that are being used at a certain period of time, and other main factors, and looking at how much attention or memory issues wax and wane as those things change over time.
So we've talked about ADHD. Is there a diagnostic term similar to ADHD for executive function difficulties? And if so, what are the key symptoms or diagnostic criteria for that?
So in our current diagnostic system, particularly the DSM, we don't have a formal label for executive disorders. In ICD, there is a symptom diagnosis where you can diagnose that there are symptoms of executive dysfunction, but it doesn't reach the level of a disorder, a standalone disorder, so that most people, when they have to use these diagnostic systems, again, will code those within either the ADHD diagnostic group or that neurocognitive diagnostic group. But clinically, people will use that. So some people will have evaluations done and be told that they have dysexecutive syndrome or executive dysfunction, and sometimes that can be confusing to understand what that means. The main features that people will talk about are difficulties with organization, difficulties with planning, difficulties with time management, and then again sometimes with emotional regulation, difficulties keeping emotions at the appropriate intensity and within an appropriate range.
Right. Okay. So we've talked about some of these already, but just again a brief overview. If you can talk about some of the key epilepsy-related factors that contribute to attention and executive function disorders, and then just talk, to the extent that you can, talk about their relative influence. So,
as you've already mentioned, Russ, epilepsy is such a complex and heterogeneous disorder. The issues that can impact memory and executive function come from a variety of things as well. So one of the first things we think about is location. Do we have a known seizure focus? If we do have a known seizure focus, particularly if it's in a temporal lobe, which is going to connect to the frontal lobe, or if it's in the frontal lobe, we have some greater concern about the potential impact on attention or executive functioning. And again, because that would imply that potentially that section of the brain isn't functioning as strongly as it might otherwise. We also, again, had this issue about when seizures are actually occurring. At the time a seizure is occurring, your awareness sometimes is disrupted, and again, that will impact what information is able to come in to be processed at that point in time. We also have impact from the medications used to treat seizures, and they can often be associated with some issues related to attention and concentration or awareness or alertness, which can have an impact. Particularly when seizures occur at nighttime, we also have disruptions in the quality of nighttime sleep and the restorative properties of sleep that can have a daytime effect then on attention and concentration. And then the stressors, it can be very stressful to manage chronic illnesses and chronic conditions, and when that is also very stressful for an individual or a family system, that can also have difficulties and reduce the sort of cognitive resources you have to work with at a certain period of time.
Okay, so can you talk briefly about the benefits of getting a neuropsychological evaluation and what's typically involved?
So neuropsychological evaluations in general are trying to look at all the different areas that the brain controls in terms of cognition. Pediatric or child-based ones tend to be somewhat longer and cover a little bit more ground because it can be a little bit more complicated as the brain is developing, making sure we're watching how all the different areas are developing. So the length of a neuropsychological evaluation often varies by age. Sometimes for adults, it may be only 3 or 4 hours of work to complete an evaluation, whereas with children, sometimes it can reach upwards towards 10 or 12 hours of work to complete an evaluation. Typically, evaluations will include assessment of different cognitive areas. It would include looking at intellectual abilities or how people reason or problem solve. It would include some measurement of attention and executive functions, how well you can direct your attention, how well you can respond to things you hear or see, how flexible you can be in your thinking, going back and forth between ideas, how fast or efficient you can be in your work, how well organized your work is. Especially with people with epilepsy, then we also really look at memory functioning, how well you can remember and recall information that you're shown or told. It may include, again, depending on, particularly on the focus of epilepsy, it may also include other language-based testing, how deep someone's vocabulary is, how easy it is to call words to mind, how well they can process and understand multi-step verbal directions. It might also include assessment of other visual spatial abilities, how well you can organize drawings, recognize patterns in what you see. And then also with neuropsychological testing, there's usually some assessment of motor skills, particularly fine motor skills, or how well you use your hands. And looking again at that right side of the body versus the left side of the body, knowing that the right side is controlled by the left side of the brain, and the reverse, that can help us look again at, is there an association between where there's difficulties if there's a known seizure focus. And then often a neuropsychological evaluation will also try to include some of that context, understanding what other issues may be present. Are there stressors that an individual is dealing with? Are they struggling with emotional issues, whether it's anxiety or depression? How much do they experience disruption in their everyday life, to help understand that association between what we see in cognition and how a person actually functions in their day-to-day life.
Right. So obviously seems like you come away with a really good understanding of the nature of the cognitive difficulties that the person is experiencing. Does the report that comes out of this also include recommendations for interventions and strategies for coping with these problems?
Yes. So a major component of a neuropsychological evaluation is not just the understanding of how someone is functioning, where their strengths are, and what are the areas that may be more challenging for an individual, but then really trying to think about how to address that. If there's a specific treatment that might be beneficial, or if there's accommodations or strategies that can be used to capitalize on someone's strengths and help with weaknesses. The reports, particularly for children, can also be used as documentation to help support school-based services or other community-based services that they may be eligible for. And it also really helps us understand, again, the course of these issues. As we've talked about, there's so many factors that can come into play. It's important for us to really look at this process over time. So if a medication change occurs, can we see a change in any one area of functioning? Do we see a specific change in verbal attentional abilities if a medication change occurs? Or do things stay generally about the same level?
Okay. So now that we've talked about the causes and nature of attention and executive function disorders and epilepsy, I wanted to talk more about how to manage these difficulties. So let's start by discussing the impact of epilepsy treatment choices on attention and executive function. So first, in general, do the cognitive benefits of improved seizure control outweigh the negative impact of medication side effects? And obviously that's a very difficult question, but if you can give it your best shot.
Right, and some of it depends, too, again, on the definition. So if we just talk about seizures, and if we just talk about a single seizure, it's not always clear from a single seizure that the benefits of medication would outweigh the risks if you only had a single seizure. But once you reach the point of being diagnosed with epilepsy, that's a different situation because now you're really at increased risk for reoccurring seizures. And depending on the nature of the seizures, some of those seizures can have impact on your overall health and safety. And so certainly whenever that's an issue, that becomes very important that that's addressed. We always talk about you have to think about the hierarchy of need. And if there's anything that impacts safety or general well-being, we have to take that into account first. So in that situation, that's going to outweigh the cognitive consequences. For the most part, too, the cognitive impact of these medications seems to be relatively minor if we can keep it to a single medication being used and keep it to the lowest possible dose needed to manage the seizures. So we still do feel like it really, the benefits to control the seizures are very important. We need to do what we can to minimize the side effects, but it's still an important treatment to use to control the seizures.
Okay. And the benefits of using medications extends beyond just seizure control too, though, because it can also have cognitive benefits if you're reducing those interictal discharges, if you're reducing the number of seizures that you're having, reducing sleep disruption caused by seizures. All of those things can also contribute to improved cognitive function.
Correct, and there's, particularly within the adult literature too, there's some concern that if you're having repeated seizures that there may be some damage that occurs within the brain, that we do see for some, thinning within the hippocampal area or other brain structures that occur when people have very long histories of recurrent seizures. And so to that extent that we can minimize the number of seizures or at least the intensity of seizures that are being experienced, that's going to be very crucial.
Okay. So you've looked a little bit at some of the medications and their cognitive side effects. Which anti-seizure medications have the most and least favorable cognitive profiles? And
so the first
all anti-seizure medications have the potential for cognitive side effects, but and it's different for every individual. But overall, what would you say?
So the one thing I want to say before I get to my overall is that one of the challenges in looking at the literature and understanding the research is we don't have a lot of consistency across our different research paradigms. So one of the struggles we've had in looking at this and really understanding how does this agent compare with that agent is many of the studies are done very differently. They're for different lengths of time. They have different inclusion or exclusion criteria, meaning they'll one study may allow people with any form of epilepsy, another may only allow people with a certain type of epilepsy. There may be factors that they control, such as the number of agents that a person is being treated with. They may use different ways of measuring these different cognitive domains that we're talking about. And so it's really limited our ability to clearly compare one medication to another. So having said that, and knowing that we only have sort of a broad brushstroke and that again, it's difficult to give a fair comparison between all of these, most of the body of research suggests that the newer medications that are developing seem to be somewhat more favorable from their cognitive profile compared to the older agents. And out of the older agents, the one that seems to have gotten the most attention or concern for cognitive side effects has been phenobarbital. That's been one that they've been most concerned about some of the cognitive side effects. Out of the newer group of agents, Topamax has been the one that's, again, had a slightly more concerning sort of cognitive side effect profile. But again, usually the correct medication to try for a first time has to do more with what type of seizures you're having and what medication would likely work best to control those seizures than starting with the cognitive side effect profile.
Have there been any studies looking at the impact of other epilepsy treatments like vagus nerve stimulation or surgery or the ketogenic diet on attention, executive function, and other cognitive functions?
So at this point in time, the majority of research on those other treatments has probably been best developed looking at surgery. Mm-hmm. And there have been two theories about what effect we might see from seizure surgery on cognition. The one is there was always a concern that if you're going in and removing a portion of the brain, you may further disrupt cognitive functioning. That if that part of the brain was actively working on attention or memory or something like that, that we could have further damage. And that's one of the reasons why, as a way to be considered eligible for seizures, people do a variety of procedures to understand what different sections of the brain are doing or how they're operating. And the best candidate for surgery is someone where the seizure focus appears to be that brain activity in there seems to be pretty low or pretty inactive, meaning it's not doing a lot. So when they remove that section, there really isn't much that they're disrupting in that way. When there's a less clear focus on neuroimaging or EEGs or in cognitive data, we have a little bit more concern that surgery can disrupt and cause some further difficulties with attention and memory. But by the reverse side, we do feel that some of the difficulties people have with attention and memory has to do with how seizures spread in the brain. So that, for example, someone might have temporal lobe epilepsy, but they may show, again, problems really more in the frontal lobe in terms of their cognition. And for many of those, it seems to be this there's sort of a spread of activity that when you watch EEG activity, it starts or its focus begins in the temporal lobe, but then as the seizures develop, there's sort of a disruption in other areas of the brain as well. For individuals with that, when surgery occurs, it becomes very helpful for cognition because now there's no more of that, or it's reducing that spread. As they've taken out that seizure focus, we don't have that spread that's occurring or sort of inciting those other areas of the brain to respond in an unusual way. And so sometimes we can see improvements actually with attention and concentration after surgery. We usually say that there's a period of time that you need to recover from surgery before you can evaluate that well. In the first couple of days after surgery, sometimes there may be what appears to be more difficulties because of sort of acute changes, but once the brain has sort of adapted to the surgery and you're 2, 3, 4 weeks out, sometimes, again, we can start seeing some improvements in areas of cognition. Go ahead. In terms of the other two treatments that you mentioned, probably, as far as I'm aware, there's the least amount of cognitive data about the VNS. There's been some early studies that have suggested that it, again, to the extent that it's actively controlling seizures, there may be some slight benefit in cognition. And then there's more recent effort right now looking at the ketogenic diet. And there are some institutions that have been beginning studies, but I haven't seen full results yet, trying to look at the impact of the ketogenic diet on cognition. There were some early animal models that had raised some concerns that, particularly in a developing brain, that this dietary change may cause some cognitive problems. But we've also seen the reverse, where there have been some early studies shown that there may actually be sort of a neuroprotective or a benefit from this diet. And they're actually now exploring, the use of this diet in Alzheimer's disease and some other metabolic conditions to see, again, if they can get this neuroprotective effect from the diet.
Interesting. So now let's talk about treatments and strategies for dealing directly with ADHD. So first, what is the role of stimulant medications in treating ADHD, both in general and in patients with epilepsy? And are they effective in people with epilepsy, and do they increase the risk of seizures? And if so, can that risk be reduced?
So if we start off talking about people with ADHD without seizures, the stimulant medications are a very effective form of treatment. Approximately anywhere between 70 to 80% of individuals treated with stimulants will report feeling that they've experienced improvement with that medication. When we look at individuals with seizures who are treated with stimulant medication, we get a fairly similar rate of improvement. So it does suggest that there can be benefits for stimulant medication in children with epilepsy as well. The issues sometimes are about concerns about what impact it may have on seizure frequency. And there's sort of two major roles that it could have in terms of seizure frequency. One is a common side effect of stimulant medication is disruption in sleep. For many people, when those medications wear off, they experience a rebound of energy or sort of brain excitement, and it makes it very difficult to fall asleep. For individuals with epilepsy, it's very important that we don't further disrupt sleep. So there have been concerns about that impact of having more disrupted sleep and what that might do to seizure frequency. We've also looked at, or there have been some concerns that some of the stimulant medication may also interfere with the metabolism of anti-epileptic medications, so that there have been concerns that you may need a higher dose of the anti-epileptic medication if you were also taking a stimulant medication at the same time. But some of the newer research has really indicated, though, that children can tolerate stimulant medication and that we have not clearly seen an increase in seizure frequency. We do recommend that when that's being considered, that it's managed by a neurologist or someone who's treating epilepsy, and probably more than just the level of the pediatrician, to really pay attention to those two issues as they come into play for children with seizures.
Okay. And what are some of the common medications that are used and which tend to be the most effective? I don't know if you have data on in epilepsy specifically, but in general, what are some of the different options in terms of stimulant medications?
So the most common one, the one that's been obviously studied the most, is going to be Ritalin. That's the one that has the widest degree of research behind it. There have been the issue with Ritalin has always been how quickly it sort of breaks down or it leaves the body, and so as a result, there was sort of a push to create sort of extended methods that would have more extended forms. The more common sort of newer medications, and these are actually sort of not the newest group. It would include things like Concerta or Adderall are sort of the other common ones that would come about. And then the more recent ones are really looking at sort of what sorts of things there could be that would be non-stimulant based that could also affect attention. So Strattera is one of the newer ones that's not stimulant based, that is designed again to address attentional issues.
Okay. And you mentioned something that maybe I misunderstood, but it sounded kind of paradoxical in that the stimulant medications, do they have a calming effect on the brain, reducing activity, or do they increase activity? Because you would think from stimulant that it cause more activity, but is it actually the opposite?
So it is sort of this issue about this rebound. So by and large, we do believe it is the medication is a stimulating effect, meaning it is sort of increasing the brain activity. But we get this still what we call a rebound effect, which is when kids come off the effectiveness of the medication, they sometimes will look more active, have a harder time settling down for sleep at that point in time.
Okay. And do medications for ADHD have similar benefits in terms of executive function? And if not, are there any medications that specifically target executive function problems?
So at this point in time, we really don't have medications that are very effective for executive dysfunction. Our stimulant medications have some mild effect for executive function, but it's most effective for addressing issues related to hyperactivity and impulsivity. That side of it has a much stronger response to the medications. So when individuals have really just the inattentive form of ADD, then we do talk about it's not always as clear-cut whether these medications will be as effective as they are with someone who has a combined version or a predominantly hyperactive impulsive version.
Okay. And when we talk about hyperactivity, does that always involve what you think people having a lot of energy and the typical thing, or is squirminess another sort of manifestation of that?
Right. I often think of it as sort of breaking it down to it can be gross motor or fine motor. And in gross motor, you have the kids that want to run around, that are jumping off walls, that are climbing, and they're moving their whole body through space all the time. But it also does include these smaller movements that are fidgety with their hands, so they're constantly playing with something in their fingers, playing with the pen cap, tapping the pen on the desk. They're the kids that don't get out of their seat but are constantly sort of changing their position in the seat and moving around in their seat. And so there's different levels or different manifestations of that hyperactivity that you can see.
Okay. So how about complementary therapies, things like neurofeedback or dietary supplements or special diets or dietary modifications? Obviously, there's limited research on the safety and effectiveness of these, and that's why they're still considered complementary. But which therapies that you've heard of have the most promise for people with epilepsy and ADHD?
So just broadly within ADHD, I would say that neurofeedback has probably had the widest degree of research that's showing some degrees of support. For those that aren't familiar with it, neurofeedback is similar to the idea of biofeedback, where you get information about your heart rate or your respiratory rate or how tense your muscles are, and you use that information as a way to figure out how to relax them or change them. With neurofeedback, you're getting information about your brain's EEG or your electrical energy in your brain. And there's certain levels in certain areas of the brain that are associated with being focused and paying attention. And so children usually are looking at a computer screen that might look like race cars racing, and one car is labeled as their car, and when their brain activity reaches that desired state, their race car will shoot ahead and start winning the race. And if their brain activity drops out of that range that's desired, their car will start to lose and fall back. And that way they can learn an association of this is what it feels like, or this is what I should be doing to sort of pay attention or feel focused. The concern sometimes has been with neurofeedback is some people will make the assumption there's no side effect to neurofeedback because it's not a medication that's being ingested, but we actually can see that some people do experience side effects from neurofeedback. And again, the most common is sort of a feeling of some degree of agitation and some disruption in sleep as a result. And again, with people with seizures, we do want to be careful about that. And there's still been some difficulty in understanding how much is it the actual feedback of information versus this taking the time every week to sit and work on paying attention. So if we have what's called sham treatments where it's not really responding to your own brain activity, there have been some studies that say neurofeedback's better than that, but there's been some that haven't. So that's the part that we're still working on, is how much of it is really the specific nature of that process versus, again, taking the time every week to try to focus on this and do something to address it. And the dietary supplements, I think, are less well supported at this point in time. Most of the research, for example, related to food dye or additives has not been as clear-cut about whether or not that's going to have a long-term benefit for cognition. Okay,
and similarly, just not a lot of evidence in terms of fish oil and those types of supplements.
Right, and some of that will depend on age. So, for example, it's particularly at sort of the pediatric side, we don't see necessarily that those things are making a difference now, but there have been studies that say, but it may make a difference in older life as the brain is aging. Things like fish oil, for example, may have more of a benefit at that point in time. Again, because of the potential interaction with any dietary issue and medications and seizure frequency, we always recommend that that's a joint discussion with the physician that's managing an individual's seizures.
Right. So lastly, I wanted to talk about behavioral and school-based strategies. And can you give an overview of some of the more effective approaches that can be used to address attention and executive function disorders, including formal interventions and then just some general day-to-day tips and strategies?
So particularly for executive functions, I think that's where we have our best array of different strategies to work on. And we do this all without realizing it. For those of us that know, I need to make a grocery list. I can't walk into the store without having a list written down, or I'm going to forget something. That is an example of using a strategy to help support your executive function or your organizational strategies. So we find that's definitely true with children at school, that there are things that they can do to support organizing information. So, for example, if a child has difficulties with organization of information, when a teacher is lecturing or giving information, they may really struggle writing their notes to create something that becomes meaningful, that they can go back and pick out organized information. Sometimes this reaches the point where what's very helpful is that the teacher provides an outline. So the teacher gives that big picture. These are the main topics that we're going to talk about. And the child then focuses more on getting the details. What are the little pieces that I need to add into this? And by being given that organizational structure by the teacher, it helps them find a way to better organize and maintain that information. Similarly, for older students, particularly at the college level, there are strategies such as the Cornell note-taking system. That's a system where your page is divided into 3 sections. In the main body, you take notes the way you normally do, and then when you go to study at night, you extract from your main notes your key terms or phrases, and you put that in one section. And then at the section at the bottom of the page, you try to do that organizational piece yourself. What's the big picture? What's the main idea of this? Why am I learning this? And again, by taking the time to sort of walk through those steps, it can help organize information to better learn it and process it. We recommend similar things when you go to read. So if you have a sense of where the material is going, you tend to organize it better to remember it. So even though parents may say, don't go to the end of the story, don't try to spoil the ending, sometimes that's a very effective strategy to go through. If you're reading a textbook, go through and read chapter headings, other sort of section headings, get a sense of what are the main points that the book is going to cover. And then you'll find when you go through and read it, it can help you anticipate what's coming and better organize that information to recall. And sometimes people prefer what we call marginal notes or glosses. So again, just by highlighting, people used to just sort of highlight as they were reading, and we find that sometimes that's not the most effective way because it doesn't really require us to be very effortful in what we're doing or thinking about as we highlight. But if you actually write things on a Post-it note, on a sticky, or in the margin of the book, and make the comment of why that section is what you're looking for, that taking that extra effort helps, again, more deeply process the information, which makes it a little bit more accessible to remember and bring back. And then in today's sort of day-to-day world, we have more and more that's available for assistance electronically. There are different apps that can be used to maintain your schedule. And we often talk about, for organizing schedules, you have to think about it at different levels. You want to think about your sort of month at a glance. What are the things going on in general for you this month? Your week at a glance, so you can see, Thursday is going to be a challenging day for me. I need to make sure that I sort of try to take care of things ahead of Thursday because Thursday is going to be a hard day. And then your actual day schedule. What are all the things you need to do that day, and what are the time intervals for those? For kids, particularly at the college level, sometimes when they think about those day-to-day schedules, they forget the things like, I need time to be able to wind down. I can't just study and then immediately go to bed. There's going to need to be a period of time where I wind down and get ready to sleep at the end of the evening. Again, people find that they remember information best in similar situations. So if you like to study with a little bit of noise, or if you like to study with absolutely no noise, when you go into a testing environment, if it can be similar, you're more likely going to remember that better. So again, if you're a person who likes to study with absolutely no noise, then it can be helpful when you go to take tests to wear things like earplugs or something else that's going to diminish the amount of background sound you have, so that you can be in a similar context. If people are very distracted by things around them, again, making sure that you sort of take the time to clear off your space so that you don't have anything in front of you can be very helpful in managing that. Another strategy sometimes we use with students is what we call a memory dump, that sometimes it can be helpful to really work on reciting and trying to sort of cram in some important key phrases just before you need to use them in an exam or in another situation. And then once that process starts, so for an exam, you might try to cram and review that material for the first 5 to 10 minutes before the exam. As soon as you're given your page, you flip it over and you dump. You write everything down that is immediately at mind at that point in time before you go through and start reading your exam. By trying to sort of get it down on page, you then free up your memory space, and you don't have to worry about trying to hold on to those pieces of memory as much once you're actually into the exam at that point in time.
Interesting. Okay. And how often is parenting style or parenting mistakes, and we obviously all make them, how often is that does that contribute to particularly executive function issues or organizational issues? If there's like a lack of structure or expectations aren't clearly defined and that kind of thing.
And I think one of the issues is this idea too that we all struggle with, is that our children are constantly evolving, and so what works at one age doesn't always work at another age. And part of the struggle in parents and in families is figuring out where someone is developmentally and what's going to be helpful at that point in time. So certainly when children are younger, they have a higher need for some degree of structure and predictability. But there's always sort of a balance point. Sometimes families go to such extremes where everything is so structured and so predictable that children never have that opportunity to figure out, well, how do you manage it when something doesn't go as you plan? How do you manage it when something's not so comfortable or not what you're expecting? And so we do struggle to try to find that line between helping things feel comfortable for children so that it is predictable and they know what to expect, but also giving them opportunities to learn that they can cope if something's not so organized or something's not so predictable. And a lot of that is, again, knowing your child's own tendencies and what are the issues that are going to be more challenging for them. Again, and then developmentally changing it. So a young child needs quite a bit of structure, but sometimes the challenge as children get older is figuring out how to fade out or turn over some degree of that executive functioning to them. One of the things that I commonly hear from parents is that children, when they're in elementary school, get a lot of support from their teachers in their schools. And then by the time they reach high school, the families have this experience of feeling like the schools just turn it off. They're just told, well, your child should manage that on their own. And there's not as much discussion about how do you make that process or that transition from having supports to being expected to do it more independently. And one of the things that I think is most helpful is really trying to think about this idea of fading. So, for example, initially you may be working with your child about their morning routine, and these are the things you need to do to get ready before school in the morning. And when children are young, a parent is probably going to be prompting them. And initially when they're very young, you're just doing one step at a time. Eat your breakfast, brush your teeth, put on your shoes. As children get older, you start stringing them together more, and that's usually when you can start introducing lists more. So now you may still be verbally prompting them through steps, but you're also introducing this idea that there'll be a written list or something that they can expect and follow. As children get better with it, instead of prompting them through the step, step one is this, you just say, remember, look at the list, and you refer them back to the list. Then it may be even a more subtle cue. Instead of saying, look at the list, you just sort of flick a piece of paper as if to, again, that's your signal of reminding about the list. And again, the goal is what can become more functional as you're an adult to be independent. So to the extent that you can transition between prompts from a person versus prompts from something in the environment, people will be more independent if they can rely on prompts in the environment versus an individual or a person to guide them through activities. So initially there has to be a lot of pairing between that support of an individual or a person and whatever that environmental sort of prompt is going to be. And then after those two things have been linked together for a period of time, then you start fading out the individual and relying more on the environmental prompt.
Right. Okay, well, that's a lot of really good information. I wanted to ask the participants on the call if anyone who's dealt with attention or executive function disorders, if anyone wants to share what treatments or strategies have been most helpful for you.
I haven't had anything that was effective.
Okay.
I try to use words that I can remember and relate those to something that I need to remember. A trigger that might help me remember something significant. So
can you think
that's
of
something that I've used.
So I know some folks use what they even call a pegging system, where if you have three things you need to remember, your first thing could be A, apple, your second thing could be B, boy, and your third thing could be C, cat. And you can try to make a mental image of seeing an apple with the first thing you need to remember, a picture of a boy holding the second thing you need to remember, and something with the picture of a cat. And sometimes those types of systems can help you remember lists. But it's also true the more you can link information to things that are familiar. So, if you met a person for the first time and they have the same name as someone else you know, or a character in literature that you know, that can be a way to help trigger or make that name easier to remember.
Anyone else have any strategies or approaches that you've used that have been helpful?
Hello, this is R.
Yep.
When the physician talked about the Cornell note, that's been something new to me this year with our daughter who's 14. And now that she brings that out, I can see where that has helped Tara a lot. Because when she switched semesters, she had to teach or help some of the kids learn how to do the Cornell notes, even though she tells me they're really stupid. I can see with what the doctor is saying that's been really helpful for her with her ADHD to try to strategize for her to remember, because testing is real hard for her. She can verbalize a lot of times what the material is she needs, but to actually physically do the test, that can be real distracting to her. But the Cornell notes have been real helpful to her.
And what your daughter was saying is what we often hear is that it does take more time and more effort to do the Cornell notes. So a lot of kids initially are not very happy to do it, and they will say that they will sort of grumble and say they don't see why they're doing that. And it does take a while sometimes for them to have enough perspective to see what impact that has on their ability to recall it. And, as what you were saying with your daughter, sometimes, again, at school, it's important for schools to think about, does extended time make a difference? Sometimes kids, when they're struggling with attention, they're less efficient in how they work through material. So having a longer period of time to work on an exam can be really helpful. And sometimes schools will also explore if kids can say it but they can't write it. Is that another way to really assess them, is to have more of oral discussions with kids as their test versus sort of a written paper pencil measure, if that's the way they best express it.
She does do better testing if her test is read to her, because comprehension is an issue for her. She reads it, but she doesn't always comprehend. And a lot of her tests, in fact, the perfect example was this week, her teacher had given it. She got 3 out of 12. She re-gave it on Monday, and it was given to her orally. She got 12 out of 12.
Mm-hmm.
It isn't always the way it is, but a lot of times she does much better when it's read.
Right, and so again, sometimes that's what we'd see with children where, especially if they have a lateralizing strength, they do a lot better with their oral language skills, for example. The more they can talk about it, it's going to be more helpful. When kids are older, those are the kids that we recommend do study groups where they can have someone that they can talk to and talk about material and not just try to look at it by themselves.
Okay, that'll be something we'll focus on with her for next year, because she will start 10th grade next year.
Mm-hmm.
So we'll try to do more study groups then with her, because she does well in her study groups. That's what her teachers just told us. So.
Mm-hmm.
Okay, then we'll focus on that. Thank you so much.
You're welcome.
Russ, this is Carla Boyd over in Grand Rapids.
Yeah.
What I'll say, my daughter was diagnosed with absence seizures back in the fall, but prior to that, she was diagnosed with several issues in a neuropsych that we now know several were attributable to the fact that she was having seizures that were not diagnosed at the time. But regardless of that, when we were more focused on the results of the neuropsych, which were Dr. Trask, a lot of the things you laid out, executive functioning issues, visual spatial processing disorders, inattentive ADHD she was diagnosed with. So I did really start focusing on the executive functioning side in my household. My daughter's 12. And I would say the number one thing, and we're pretty organized to begin with, but I became hyper-organized in my house because I found that was really helpful to her. And an example of that, I have a cabinet where the kids keep all their school art supplies, markers, crayons, glue, whatever. I took it probably 5 steps further than your average parent, where I put little drawers in there and P-touch labels on everything. And I found with my daughter that when I prepare the framework for her, it helps her tremendously. And it just goes with, I don't know how much that ties into a possible visual spatial issue that she might have, but, if in a child like my daughter, if her room's a mess, she won't find anything. But if we have that predictability, if all of her sweaters are in one drawer and all of her jeans are in the other drawer, it's really helped her. What I do struggle with is, when do I start pulling back more and help her self-organize? And as she's getting older now, I realize that'll be more of an issue that I've got to help her figure out how to do this stuff on her own, and we're really approaching that. But just generally to your question, Russ, I found that specifically with executive functioning, having an incredibly organized house has made our lives a lot easier.
And I think part of what you're saying, I think, really does correspond to what you mentioned with your daughter having some visual spatial deficits. It's really hard when kids have deficits in visual spatial systems to be able to see things, to be able to find something from a cluttered array or from a messy array, but they don't always recognize that that's what's making it difficult for them. So again, having things very clearly in place and in position can really help kids quite a bit. Sometimes we do recommend that, the process of teaching them, for example, how to clean their room, because usually even after you get it all organized, at some point in time it's not going to remain everything in its exact place. That again, that first step is saying, okay, I want you to pick up all of your sweaters and put them here, and you do it sort of single step, eventually working up to where you have a picture of what's organized on the shelves. And the goal is for her to be able to say, my shelves look exactly the same as this picture again. They're the same as they were before. And that's the goal that you're always trying to go back to. But many kids will need some steps to figure out how to reach that goal of looking like the picture again, and some prompts along the way of where the pieces, first picking up everything off the floor, now sort them into clothes versus books. And then sort the trash out or whatever it is. And then that going through those sort of systematic processes, then again you'd pull back and say, well, we've cleaned the room a lot together. Remember, our first 2 steps are to get everything off the floor and to sort 2 piles. I'll be back in 5 minutes and check on you. And so you start fading out how much you're present and how many things you sort of clump together in that process as kids get more and more independent.
Yeah, and that's a great point. And one anecdote I'd like to share, especially with the parents on the call, my favorite one with Lane, and Dr. Trask, I've learned to assume nothing. Mm-hmm. I think like with my son, I can assume that he's watching me and picking up how I do things. And with my daughter, it's different. And the quick anecdote I'll give, she went to an overnight camp just for one night with her school. I knew she had these issues. She was taking a lot of stuff with her. I prepared a very detailed 1-page checklist, literally with boxes for her to check off, with her sleeping bag, her toothbrush, told her, when you get there, go through the checklist, make sure you have everything. When you're packing up, go through the checklist and make sure you have packed up everything. I even provided a pencil for her in the envelope. When she came home, she had forgotten a couple of things, and I said, honey, why didn't you go through the checklist? And she said, I did. And I said, but you didn't check anything off. And she looked at me and she said, you didn't tell me to. I mean, that for me, like I can't even describe, and I really understood what I was dealing with then. That I could never assume anything.
Well, and I think that also speaks to a component we didn't talk about with executive processing, which is initiation. So initiation, the getting started or doing something and acting, is a component of executive functioning as well. So a lot of kids might know what they need to do, but they can't quite get started, and that's where they need that assistance to figure out, now is now the time I get started? Is now when I do it? And they become reliant on others to help prompt them for that.
Okay. Other questions or comments?
This is Laura Weintraub in Ann Arbor. If I could share a couple things. I've got 2 kids, both with a history of epilepsy and both diagnosed ADHD, one inattentive type, my son in 2nd grade, and my daughter who's a 6th grader with more of the combined or hyperactivity. And a couple of things that we've found that's worked well for our family is really working with the school system to get them the support they need through an IEP plan. And that was a difficult battle, particularly with my daughter. And but we did win that battle, and she now has an IEP in place, and that's helped immensely in her first year of middle school. She's been able to get an academic support hour as part of her day where she's working with a teacher consultant, and it just lets her really regroup and do a lot of her most difficult homework with that teacher in a small group or one-on-one, and it's really decreased the amount of battles we're having at home with explosivity and with frustration over homework, and she gets to just get reinforcement of what she needs, where she's got those gaps, and that's particularly related to math. So that's been really helpful to not give up and push hard to get the support needed in the school system, and also getting the teachers on board with understanding their challenges with the executive functioning and, you know, turning in assignments, needing to sit in the front of the classroom, all these different things that can help them in the school setting. The other thing with her assignments, you know, we're able to look online, and every few days I review it with her and say, oh, this worksheet's missing or this homework assignment's missing, and you know, trying to give her the independence to take care of that herself, but also saying what system's going to work for you. And so she makes little sticky notes. She sticks in her folder, so that's the first thing she sees in the morning, remembering she's got to dig that paper out and actually turn it in, even though she completed it 2 days ago and just didn't get to that last step. So trying to put the emphasis on her being more independent, but again, with the lists and the sticky notes, seem to be helping her, and it gives her a little more control of the situation. And then the third thing I mentioned that we went through with both kids is some family counseling, which was very helpful just for all of us to understand. They were both diagnosed at the same time, and that was about 2 years ago, and my husband and I had a lot to learn, and the kids both had a lot to learn as well, understanding how their brain works and what their challenges are. And so going through that counseling process was really good for all of us to put some understanding to those times where it's so hard and everything kind of blows up at home. And now we know why, and we can be a little more supportive to each other and, you know, figure out strategies rather than just letting those times consume our household.
And I think that is a real important thing, is really thinking again about the whole family system, because what's happening with one person, you know, will impact everybody around, and so you really want to figure out how to work together as a unit, and that can be really helpful to have those folks outside sometimes who aren't emotionally invested to step in and to talk about ways to manage that and deal with that. And I was just going to also comment that you sound like you've done a number of lovely things with your kids and helping them sort of, especially with the school process. One thing that we've also encouraged kids to do as they're getting supports at school, in that idea of transitioning, of thinking about as they're going forward, really helping them be able to write down, these are my strengths as a student, these are the things that are more challenging to me, and these are the things that are most helpful to me. And initially, that being something you sort of do at home, but working with kids, particularly when they're at the middle school and high school level, that be something that they bring to school, and they start taking the initiative to schedule a time to talk to the teachers and share that with the teachers. And again, initially, the adult being present. So you arrange a time when your child and you can both go together to the teacher. And initially, it might be my child has something to share with you, and they, pass it over, and the adult does more of the talking. But again, modeling for the kids how they will do that as they start reaching further on in high school or in college, about how to advocate for themselves and take over that role for themselves of really speaking up for what they need and what's going to be best for them.
Yeah, and just real quick, I can share that example. My daughter was placed in her language arts class. Her first seat for the year was right next to the group discussion table, And I came home and said, okay, where are you sitting in each class? And several of the teachers had read her IEP and stuck her right in the front, and then a few didn't quite get that message. So she was, I think, near the front, but really in a not very good place. And so she was very comfortable, and she went and talked to the teacher and said, you know, I get really distracted if I'm sitting by the group discussion. And so I was very proud of her for figuring that out, that that wasn't going to work for her, and she was comfortable talking to the teacher about that. So a good example where I kind of encouraged her to do the talking, and she was okay with that.
Yeah, and that's a great opportunity for her to learn about that.
Great. Other comments or questions? We have about 5 minutes or so left.
Could I get the name of the counselor that the last caller had mentioned she used? Because I've had a hard time finding counselors who understand a lot of the epilepsy and the impact they have with the frontal lobe disability.
I can tell you where we went. It was in Ann Arbor, Michigan, with the University Center for the Child and Family, and it's a counseling group that works as part of the University of Michigan. I don't know if they per se have a lot of experience directly with epilepsy. They are very familiar with ADHD. How we got into them is they had some informational sessions that they did, like in a 3-part series, and my husband and I attended. And they, we kind of learned, it was a good information-seeking experience for us. And so then after that, we called them up and found out opportunities for counseling. And they tend to work with postgraduate fellows as sort of the primary clinicians that you work with. But then I think there's some oversight there. So we had a good experience. And so if you look through University of Michigan Center for Child and Family, their website gives a lot of information and contact information.
Thank you. I appreciate that.
Okay. Other comments or questions?
I do.
If someone 50 years old with ADHD were to be started on a medication that showed positive benefits, how much could they expect to benefit?
So again, it's not always clear how much any one person would benefit. We have a greater sense of, as a group, what percentage of people would show a benefit out of a group. So these medications would still be beneficial at pretty much multiple different age points, and most people would say that they feel a benefit of being more productive, feeling more efficient. Sometimes what I encourage folks to do if they're going to start a medication trial, to start off, on a 1 to 10 scale, rate yourself. How focused do you feel? How efficient do you feel like you are in your work? Get a good baseline for a week or two of how those days go by. Then go ahead and start the medication and sort of keep rating yourself. If you have someone in your life that's close to you, it's also helpful to have them rate what they see or make any comments about what they see, and then have an ability to step back and look at that and say, okay, is that enough of a change for what I'm looking for? Is that what I'm looking for in terms of a difference?
Thank you.
Another person had a question?
Yeah, Dr. Trask, this is Carla Boyd in Grand Rapids again. Have you been involved with any research, and I know it's not a DSM-identified disorder. My daughter was diagnosed with nonverbal learning disorder. Yeah. What ties, or do you see strong ties between that and epilepsy, particularly absence seizures?
So I wouldn't necessarily link it to absence seizures, but what I would say is that when we look at the brain in general, if you look across different medical conditions, the nonverbal side of the brain, the right side of the brain, seems to be much more vulnerable. So particularly any child that has had some sort of significant or chronic health issue in childhood, they seem to have a greater preponderance of problems with that right hemisphere and nonverbal learning side. Again, it's hard to know if it's because the brain is always protecting language development, and that's what leaves that side more vulnerable. We also know that the right side of the brain has longer tracks or longer connections, whereas the left side of the brain has shorter tracks. So there's less chance or less room for something to go awry within those small tracks versus within the larger tracks. So I also see children, for example, who have been treated for cancer. They're much more at risk for nonverbal learning problems than the language-based processing problems as well.
Thank you.
We have time for maybe one more question.
In the neuropsych testing, is it considered the medication and being in a strange environment Are all that stuff considered when you do that testing?
Yes, and that's part of what makes it an art form and not just sort of why a computer can't completely do a neuropsych all by itself, is that's part of what we're factoring in. We take information about people's histories, about what medication they're on, how long they've been on that medication. We try to also pay attention to how comfortable a person feels in the situation. Does their behavior change at the beginning when they're less familiar or maybe less comfortable and then, as they become more familiar, does their performance change, or the reverse? Do they appear to become fatigued, and do we see a change in performance that could be related to fatigue that occurs over the course of the evaluation?
Thank you.
Right. You also have to look at seizures as well. Have you
Correct.
A seizure? Are you still recovering from that seizure and that kind of thing as well?
We usually don't recommend that neuropsych testing be done if we know someone is in the post-ictal period, if a seizure's occurred very, very recently. If it's the day before and you're still feeling somewhat tired, that's important, and there may be some discussion about whether, for myself in my own clinical practice, I might do some assessment at that point in time and then ask the person to come back and do some more, and then we have a nice comparison to look at what is it like in those moments where you're somewhat drained versus when you're feeling fresher at a different point in time, and do we see much difference in cognitive performance under those two situations?
Okay, well, thank you so much for your time, and I learned a ton, and I'm sure everyone else did as well. Thank you, everyone, for participating and for sharing your stories and what has been helpful for you. So really appreciate that. And again, thank you, everyone, for participating.
And thanks for having me.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.